The next presentation by Dr. Sakthivel from Medicine 3 on Schmincke.
Good morning, Monandal. On behalf of Medicine 3, I am presenting Schmincke. So here, a 19-year-old trainee at 27 weeks of gestation from Tirupattur presented with complaints of right post-auricular swelling for 2 months and fever for 2 months. History of presenting, she was apparently normal 2 months back. Followed that, she noticed insidious onset, gradually progressive unilateral swelling. Initially, it was painless. Later, it became painful and associated with low-grade fever, which was intermittent on and off with evening raise of temperature. There is no history of any loss of weight, appetite, or cough with expectoration. No history of any ear pain, discharge, difficulty in swallowing. No history of any rash. No history of allergy, seasonal exacerbation, or nose bleeding, or no history of any neck swelling. So on examination, vitals, he was vitally stable with no pallor, icterus, cyanosis, clubbing, or pedal edema. On lymphadenopathy, she had right cervical. 5 nodes were class 5 nodes were involved. 3 to 4 nodes, which was matted, immobile, not warm or tender. So in neck, no midline swelling or cyst. On oral, there is no dental caries or tonsillar enlargement. On systemic examination, CVS, it was S1, S2 here, no murmur, RS normal vesicular birth sounds. On abdomen, it was soft, distended, corresponds to 28 weeks of gestation. CNS, no focal neurological deficit. Before entering into our differentials, I like to talk about the lymphatic drainage of the head and neck. So initially, the group of lymph nodes involved in the lymphatic drainage of head and neck was submental, submandibular, then pre-auricular and post-auricular. All will drain into the deep cervical lymph nodes of 2, 3, 4, upper, middle, and lower cervical lymph nodes. Then it will enter the pre and paratracheal lymph nodes. So mainly in the post-auricular nodes will drain in the scalp associated with the ear canal, and the pre-auricular part also it will drain. So level 5 includes the nasopharynx, thyroid, paranasal sinus, and the posterior scalp. So before entering our systemic differential, initially we want to rule out the local causes of the post-auricular lymphadenopathy. So the local causes we initially looked at as in ear, ASOM, CSOM, pharyngeal, and otomycosis. And in nasopharynx, pharyngitis, polyp, retropharyngeal or parapharyngeal abscess. And in the paranasal sinusitis we looked at, and scalp pharyngeal cut. These local causes all were negative. So we enter into the next differentials we included as broad spectrum bacterial, mainly considered as a tuberculosis. Next, viral, mainly Epstein-Barr virus or cytomegaloviruses, and human immunodeficiency virus and syphilis. In fungal, toxoplasmosis and histoplasmosis. And autoimmune diseases, it's unlikely patient doesn't have any joint pain, ulcer, rashes, but we included in the lower end. So systemic lupus erythematosus and rheumatoid arthritis. And malignancy we mainly consider was leukemia, lymphoma, and from metastasis or squamous cell carcinoma from head and neck. So the initial investigation, his HB was 10.1 with microcytic hyperchromic features, with counts was normal, with LFT showed direct indirect total bilirubin of 0.2 with direct of 0.1, with total protein of 6.5 and albumin was 3.2, and urea, creatine, and electrolytes were normal. So for our differentials, we sent 2 blood cultures, it was negative. BBVS and VDL screen was also negative. His initial inflammatory markers was elevated, ESR of 105 with CRP of 36. So we further went to ANA, so it was came as 1+. We further evaluated DS, DNA, C3, C4, all were normal. IgG also normal, and ACV sent for in view of sarcoidosis, it also came as normal. So we did for ultrasound neck of the post-auricular level 5 nodes. It showed cervical nodes in the right side only. Left side is there no nodes, only unilateral side with clumped nodes with loss of fatty hilum. With architecture nodal largest measurement was 3x3. So loss of fatty hilum may mostly suggestive with only infiltration or malignancy. So we did for FNAC initially. So the FNAC showed paucicellular. Only atypical cells clusters were identified. So another time we went for direct nasopharyngeal scopy. It showed also normal. So the FNAC shows anti-atypical cells clusters with ultrasound shows loss of fatty. We probably consider as a malignancy as a final differential. So we looked at one article. It is a head and neck surgery with squamous cell carcinoma. It showed occult malignancies where we look for. So this is the algorithm showed if patient presents with ST or neck mass. So we initially we go for ST and physical examination and direct laryngoscopy. If it's become also normal, then we go for ultrasound guided FNAC or biopsies. If primarily itself we consider it is a squamous cell carcinoma, we can directly go for human papilloma virus. Otherwise, we can go for imaging studies. This after that, if imaging studies CCT, MRI, or PET scans are also negative, we can go for induced anesthesia and evaluate for further. We look for malignancies. If it's also primary is not identified, then we go for transoral surgeries. Then after the last we come back as a head and neck squamous cell carcinoma of unknown primary. So we went for biopsy, ultrasound guided biopsy. It showed the neoplasm of arranged cells with nest cards and trabeculae with atypical polygonal cells, and there is no evidence of keratinization. So it is a non-keratinized tumor. There is no necrosis or lymphovascular invasion. In the immunohistochemistry, it shows strong positive CK and P40. CK and P40 more suggestive of the skin squamous cell involvement. So it is a non-keratinized squamous cell carcinoma with mild positive of Epstein-Barr virus latent membrane protein 1. So we sent for expert and it shows low positive with intermediate resistance, but MG showed no AFB and fungal also was negative. So patient was atypical presentation. We didn't start with the ATT. And we go for MRI, MSK whole scanning in your pregnancy. So it showed there is a large lobulated heterogeneous mass in the from the nasospharynx extend to the clevis up to the oropharynx. And there is unilateral retropharyngeal nodes involvement, mainly associated with right level 5 nodes. So final. So this is a clevis bone extending from the base of the skull to the cranial vertebral junctions. So our nasopharynx will be start from the base of the skull to the soft palate. So this is where we usually see the occult malignancies mainly arising on the fossa of Rosenmuller or Rathke's pouch. So this is where we missed some malignancy, the paravertebral spaces also. So final diagnosis we included as carcinoma of nasopharynx with T3N2 with histopathology non-keratinizing squamous cell carcinoma. So I would like to talk about something about the nasopharyngeal carcinoma relation with the Epstein-Barr viruses and how to approach in head and neck occult malignancy mainly by anatomical and histopathological. So first, the Epstein virus relation with the carcinoma of nasopharynx. This is an article released in the Chinese in 2019. The Epstein virus is a persistent, lifelong asymptomatic infection in the 90% of the individuals. So it mainly accounts 82% of nasopharyngeal or gastric carcinomas. Mainly in the endemic regions, it is mostly associated with 90% of the incidence, but causing 100% mortalities overall. So the nasopharyngeal carcinoma will be 3 types. The type 1 is the squamous cell carcinoma. Type 2 is the non-keratinizing squamous cell carcinoma, which was differentiated, and type 3 is the non-keratinizing squamous cell carcinoma, which was undifferentiated. So mostly in the type 2 and type 3, it was 100% prevalence of Epstein-Barr virus is there. So if we diagnose yearly, the 5-year survival was 93%, but late stage, if we diagnose, it will come as a 73% of survival. So the pathogenesis, mainly the Epstein-Barr virus will cause the latent membrane protein. This latent membrane protein involve cause the down regulation of the DNA damage binding protein. It is mainly involving the nucleotide excision repair. So it is causing the malignancy profile. So initially it will infect the cells, then latent infection will come and produce the latent membrane proteins that will cause the later produces the malignancies, mainly causing the epigenetic alterations and immunomodulatory and immunosuppression in the local environment, causing the malignancy profile. So in the anatomical, in previous years, initially we used as an indirect laryngoscopy used for to assess the upper part of the larynx, nasopharynx or oropharynx. In that time we cannot able to visualize most part of the some 5 parts. One is vallicula, base of the tongue, and upper fossa of Rosenmuller, Rathke's pouch. We cannot able to look into the indirect laryngoscopy. Follow that, we developed the direct laryngoscope with fiber optic measures. In that time also we will look at all these structures. But if the malignancies are less than very small or if it cannot ulcerative or proliferative growth, we cannot able to see also. That time only biopsy is the main, or next we go for MRI imaging to rule out these occult causes. So the anatomical diagnosis cause of problem is retromolar of trachea and the rapid coach. So in the anatomical, the MRI brain show the most of the occult primary areas where the malignancy will come as. One is the this is the retropharyngeal space and pre and paravertebral spaces, and this is the carotid space, and this is the posterior cervical space. Where is the, if a small arrived these areas, we cannot know. In the nasopharyngeal laryngoscopy also we cannot able to see also. So I want to talk about the head and neck. This is article release. Head and neck commercial carcinoma of unknown primary. Can ancillary studies help identify more primary sites based on the histopathological evaluation? How to localize the tumors in the head and neck? So based on the viral test itself, here the 22 patients were included. In this 22 patients, 12 patients were human papillomavirus test was positive. So they were mainly considered as a oropharynx syndrome. In the negative patients were further evaluated for Epstein-Barr virus. Next step. In the Epstein virus is positive, mostly it was associated with the nasopharynx or salivary glands. If it's negative, we will go for c-KIT and CD5. The c-KIT and CD5 mainly associated with the thyroid glands. So if c-KIT and CD5 positive, it's mainly to the thyroid glands. If it's negative, we further evaluate due to the skin involvement is there not. For that, we went for ultraviolet multi mutational signature. So it showed positive, it's mainly from the cutaneous surgeon. If it's negative, it's more we look into the hypopharynx or larynx or any other cause. For lymph node involvement, if the lymph nodes of level 2 or 3 or non-level of 2 or 3, we need to say. If the lymph nodes 2 and 3, we did for histopathology examination, HPV staining, immunohistopathology. If it showed positive, it's mainly from the oropharynx. If it's negative, we another immunohistopathology showed Epstein-Barr viruses we analyze. If it showed positive, it's potentially mainly arising from the nasopharynx or salivary. If it's negative, we again go for mutational signature analysis. So this is a retrospective cohort study. It was done in our CMC oncology department. It released on 2020. Showed pregnancy outcomes in the non-gynecological and non-hematological cancers. So overall, if, in the cancers in the females, only 10% will manifest during the reproductive age group. Though mainly it was classified as a gynecological or non-gynecological. Here we mainly focus on non-gynecological and non-hematological. Other than hematological, colon, other bone, all tumors. So here we included, it was analyzed for over 10 years retrospectively. So included 41 patients, in which 13 patients was already diagnosed and came as a pregnancy, and 28 patients were diagnosed during the pregnancy. Out of which 50% were delivered around 31 to 35 weeks in view of to yearly start with chemotherapy or radiotherapy. But in severe malignancy included patients, we were yearly termination of pregnancy was advised. So here in previously known case of diagnosed women who underwent who are now gave us a pregnancy, most of them associated with thyroid malignancies, 11%, and followed by breast cancers. In during the pregnancy, who are diagnosed as a malignancy, mostly associated with breast carcinoma is more than the CNS involvement. In our head and neck, the frequency were 5 patients, but all were mostly ended into the normal vaginal delivery only. So coming back to our patient, we started with the first cycle of carboplatin and paclitaxel. After that, patient was under follow-up with med-oncology. So learning points is approach to cervical and outcomes with pregnancy. Thank you.
Questions? Is there any other data outcomes present in our data? Is there any other global data on esophageal carcinoma, ED, flare, pregnancy?
So,